Good evening, everyone. Welcome. Thanks so much for joining us for this UMiami Health Talk, Allergies or Sinusitis, Understanding the Difference and Modern Treatments. We know this is a hot topic, judging from the many of you joining us tonight and have been in the waiting room waiting for this to start. I'm health journalist Ileana Bravo, your moderator for this evening's webinar, which is presented by the University of Miami Health System's ear, nose, and throat experts. UHealth is recognized throughout South Florida and the world as a leader in treating conditions and disorders of the ear, nose, and throat. Our team uses the latest technologies and research-driven expertise to provide you with superior personalized care and the best outcomes. So we invite you to learn more about conditions that can affect your ears, nose, or throat and the impact they can have on your quality of life by visiting umiamihealth.org/ENT. To schedule a consultation, call 305-243-3564. No worries. We're going to repeat that information again at the end. You're going to have the opportunity to see that contact info. And appointments, by the way, are now also available at our newest facility, the UHealth Doral Medical Center, which is incredible. So tonight, our esteemed panel of experts will discuss some of the most common and often confusing topics surrounding allergies and sinusitis. At the end of the presentation, there will be a Q&A session, which is a unique opportunity for you to take part and ask direct questions of our experts. Please use the Q&A feature at the bottom of your Zoom screen. Take a moment to look at your screen, and that's where you're going to submit your questions for us to direct to them. So it's my pleasure now to introduce our first speaker, Dr. Aura Acosta. Dr. Acosta is an ENT specialist with over 20 years of experience. She completed her medical degree with magna cum laude honors, followed by residencies in general surgery and otolaryngology and a fellowship in rhinology. After 13 years in private practice in Caracas, she joined the University of Miami in 2020, lucky us, where she focuses on rhinology and leads the otolaryngologic allergy clinic. Let's welcome Dr. Acosta. Make sure you are unmuted and ready to go with your presentation. Welcome.
Thank you so much, Liana, for the presentation. This is very exciting. This is what we do every day. It's our passion. And as you say, it's a very confusing topic. Okay, so let's try to find the answers for so many questions. Can you see my screen? Yes? Okay. So first of all, what is allergic rhinitis? Allergic rhinitis is an overreaction of your immune system to normal substances that are in the air, like pollen, dust mite, pet dander, and mold. Now, what happens when I have nasal symptoms when I expose to strong odors? So this is a very common question that we get in the clinic. And I would like to explain that the following way. If we see the word rhinitis, that means inflammation, okay? But when it's allergic rhinitis, means that that inflammation is coming from an allergen, is coming from an allergic reaction, okay? Now, what happens when the inflammation is not coming from allergies? This is the case of the patients that complain of allergy symptoms or nasal symptoms when they are in contact with the strong odors, perfumes. They used to ask, hey, I have allergies to my perfume. It's not that you have allergies to your perfume, it's that you have a rhinitis, that means an inflammation of your nose, when you are exposed to strong odors, and that can also happen with certain medications, can also happen due to hormonal changes during pregnancy, elderly, or maybe because of a substance that you are exposed in the place where you work. Now, the prevalence of allergic rhinitis worldwide is 5 to 50%, but that depends on the geographic area, the population density, and also the methods of diagnosis. In US, 10 to 30% of the adults suffer from allergic rhinitis, and as many as 40% of the children are also affected. So this is a very important disease, and in fact, is the fifth most burdensome chronic condition when we consider total cost. These total costs are divided in the cost that we have to diagnose the disease, to do the prevention, to do the management, but there are also indirect cost, which is the cost related to the reduce of productivity. But why is that? Because this is a disease, the allergic rhinitis, that can interfere with the cognitive functioning, can cause fatigue, can cause impaired learning, concentration, critical thinking, and that is something that affects the quality of life of the patients that suffer this disease, okay? Now, this is an annual report that is published by the Asthma and Allergy Foundation of America, where they rank the major cities that have to deal with the highest pollen levels of pollen, okay? Even when we are not in the top 10, we have 5 cities, okay, between the first 50 places. We have Jacksonville in the place 20, and we have Orlando in the 34. To give you an idea how the pollen have increased over time, Jacksonville, I have to tell you that Jacksonville jumped from the position 71st in 2024 to the position 20 in 2025. New Orleans jumped from the position 34 to the second place this year. So that means we are having an increase in the pollen levels worldwide, okay? And you will be wondering why, okay? This change in the levels of pollens is related to the climate changes, okay? The most important factor in this increase is the increase of the levels of the CO2 and other substances that are in the environment that contribute to a warmer weather, warmer temperatures. So that means more pollen in the air, longer pollen seasons, and in fact, the pollen season is overlapping. Also, there are new allergens in new places. The higher levels of pollutions is going to make the allergies worse. And all these factors are going to lead to an increase of the pollen levels and in the allergy symptoms. So the type of allergic rhinitis, we have patients that only report symptoms in certain seasons. That's 20% of the patients. And this is frequently associated to outdoor allergens. So we have grass pollen, wheat pollen, and tree pollens, okay? There are other patients that have symptoms that are all year round, and usually these symptoms are associated to indoor allergens, roaches, indoor mold, pet dander, dust mite, okay? But 40% of the population have mixed allergies. Means that they can have perennial symptoms all year round with peak of exacerbations. So what are the symptoms of allergic rhinitis? Sneezing, runny nose, and nasal congestion are the most common symptoms. But we have also itchy throat, itchy eyes. We can have also skin manifestations, okay? Now, this is a very common question, and patients are surprised in the clinic when we talk about this. Can the allergic rhinitis cause sinus congestion, facial pain, and headaches? The majority of our patients come to the clinic complaining of these symptoms and claiming that they have chronic sinusitis or sinusitis. So guess what? Allergic rhinitis can cause sinus congestion, facial pain, and headaches. And in fact, if we see this graphic, this is a study that was done and shows the symptoms of the patients with seasonal and perennial rhinitis over time. So we have, as you can see here, you have that the patients can complain of sinus pressure, headaches, and postnasal drip, okay? And this is very confusing because these are the same symptoms of chronic sinusitis. Regarding to the other symptoms that the patients can complain, or more frequently they complain, is headaches. The majority of the patients with headaches and facial pain thinks that they have sinus disease, but 86% of the patients that complain of sinus headaches meet criteria for migraine, and only 3% of the patients meet criteria for sinusitis. At this point, you probably very confused, and then you say, okay, how am I going to differentiate migraines, allergic rhinitis, or sinusitis if they have the same symptoms? Some of these diseases, like 30 or 40% of the patients with allergic rhinitis have asthma, and 80% of the patients with asthma have allergic rhinitis. This makes the symptoms even more confusing, right? And also, there is a strong association between allergic rhinitis and sinusitis because both diseases can frequently coexist. Okay, so how am I going to differentiate these patients? How do I know that if they have allergic rhinitis or chronic sinusitis? So in the case of allergic rhinitis, the diagnosis is based on the patient history. Unlike sinusitis, which has a specific criteria and guidelines that define the diagnosis of allergic rhinitis is a clinical diagnosis. It's through a detailed history. Then we have the physical exam. Yes, there are things that might be very pathognomonic of allergic rhinitis, like the patients having allergic shiners, which is dark circles in the lower lip, or the nasal crease. And when we see inside the nose, this is something that can help us to differentiate between allergic rhinitis and chronic sinusitis. They usually have inflammation inside the nose. Typically, they have enlarged inferior turbinates, but there are other findings in the physical exam that can guide us to make the diagnosis. We don't use imaging to diagnose this disease, but we use the imaging to rule out other causes of the nasal symptoms. Allergy testing is one of the tools that we have, but we don't really use allergy testing to diagnose the disease. We use it to confirm our suspicions, or in patients that are interested in treatment as like immunotherapy. Something that I really want you to take home is that a positive test in either skin or blood doesn't mean that the patient have allergies disease, okay? This only means that you have a sensitivity. But when I have a positive test, I have to correlate the symptoms of the patient with this test. So if I have a positive test plus symptoms, that is a true allergic disease. But if I have a positive test and I don't have symptoms, that is just a sensitivity. And I think that the best example for this is food allergies. We see a lot of people that come and say, hey, I was positive to strawberry. I cannot eat a strawberry. That's not true. The positive test only means sensitivity. If you eat the strawberry, the strawberry and you don't have symptoms, you can continue eating. So the same applies for environmental allergies. So the treatment is something important is that this is a chronic disease. There's no cure for allergic rhinitis. The main treatment is avoidance, is avoid everything that I think that triggers my symptoms. Then we have the medications in the way of nasal sprays, allergy pills, saline irrigations. And then for the patients that don't want to take medication forever, the patients that want to change the course of the disease, then they have the option for the immunotherapy. Immunotherapy is the hope for the cure. We have immunotherapy as a shot, okay, in where we inject the allergens that you are allergic to, so your body start developing tolerance against those allergies. But we also have sublingual drops and some tablets. And this is another way of delivering immunotherapy. And in fact, the FDA has approved 3 tablets for house dust mite allergies, ragweed, and grasses. We can also formulate allergy sublingual immunotherapy drops, okay, if the patient prefers to do drops and not shots. There are other options that, like, for example, we have a toothpaste that the patients can brush their teeth, and that can help to deliver immunotherapy, intralymphatic immunotherapy. But I think that the most exciting that we have, because it's something that we can use also in chronic sinusitis, and David is going to talk about, is the biologic medications. But what are biologic? This is a monoclonal antibody. What is a monoclonal antibody? These are proteins that are created in labs that block specific areas of your immune system. So when we have an allergic rhinitis, when this antigen make contact with your body, there's going to be a release of many substances and cells that are the responsible for the allergy symptom. Well, right now, there are some products or new medications that are targeting a specific substance or cells that are responsible of these symptoms, okay? For example, I'm going to give you an example. This is the omalizumab, which is a protein that is going to block IgE, which is one of the most common cells that can trigger the allergic response, and is now approved for food allergy. There is currently clinical trials to approve omalizumab for allergic rhinitis. Imagine that you can treat your allergies with an injection every month or every 2 weeks without the need of taking allergy pills or nasal sprays. This is the future. Is still not approved for the FDA. There are other monoclonal antibodies, which is the same. It's a proteins that might stick to certain receptors that are in the cell, and that's going to prevent the delivery of those substances that cause the symptoms. So in conclusion, we know now that the allergic rhinitis and sinusitis frequently coexist. The diagnosis is a clinical diagnosis, and the ENT evaluation is essential to differentiate these two pathologies. Allergy testing helps to confirm the diagnosis and is the base for immunotherapy, but we don't need it to make the diagnosis. There is no cure for allergic rhinitis. The most important in allergic rhinitis is avoidance, and the hope for the cure is going to be the immunotherapy. And the new biological medications are are proteins that target specific areas of your immune system that are currently approved for food allergies and nasal polyps and under study for allergic rhinitis. Thank you.
Thank you, Dr. Acosta. Super eye-opening, important information. And the future looks bright with the monoclonal stuff. All right, let's open it up to our next speaker, Dr. David Lerner, a rhinologist and skull-base surgeon at the University of Miami. He completed medical school and fellowship at the University of Pennsylvania and residency at Mount Sinai, New York. His clinical focus includes sinus disease, skull-base surgery, and sinonasal tumors, with research interest in smell disorders, healthcare cost, and pediatric skull-base surgery. Let's welcome Dr. Lerner. Make sure you're unmuted.
Hi, everyone. Thank you so much for having me. And thank you very much for the introduction. I am very excited to talk today about allergies and sinusitis, understanding the difference and exploring modern treatments. Okay. So Dr. Acosta did a wonderful job outlining many of the key points that we have today for our talk, with a focus on allergic rhinitis. In my portion of the talk, I'm going to explore a little more on chronic sinusitis, going through the different types of classifications that we have now and how we are able to tailor treatments in the modern era for each particular patient's disease. As Dr. Acosta was going into towards the end of the talk, it really is an exciting time in medicine. We have a bunch of new medications that we can tailor for each specific patients, and we're better using technology in order to get a better understanding of how the disease processes with all of our patients differ. So for sinus disease in particular, we know that we have a variety of established effective treatments like sinus surgery, as well as topical rinses with things like steroids, as well as newer medications that are targeted like biologics and macrolides. So now that we know a little bit about allergic rhinitis and chronic sinusitis, who gets chronic rhinosinusitis? It is overall quite common. It's estimated that between 5 and 15% of all people have it, with numbers varying based on location and ethnicity. So not quite as common as allergic rhinitis, but still between 1 in 20 and 1 in 6 people. Is more common among folks who smoke cigarettes and those with more exposure to pollution. And it's more common among patients with asthma. And we'll talk a little bit more about that connection later. Beyond these specific factors, there's a whole bunch of other genetic and environmental factors. So it's really not just one thing that leads someone to develop this disease process. One of the reasons why I like treating sinusitis so much is that it really does affect people's quality of life to a pretty huge degree. And I feel like as ENTs, we have this enormous opportunity to help people. This is a graph from a paper that looked at how different people report the impact of their disease on their quality of life. And they included a whole variety of different diseases, and they asked patients to rate how much it affects them from 0 to 1. 0 being about as bad as it gets, and 1 being they're perfectly healthy. As you can see here in the middle of the graph, patients with chronic sinus disease are actually, they rate themselves worse than folks with COPD or coronary artery disease, and just slightly better than patients with end-stage renal disease who are on dialysis. So a lot of these patients are really suffering. Zooming out to a more global scale, there's an enormous economic impact of sinus disease. This was the same study that looked at the economic impact as measured through things like missed work time and loss of free leisure time. And they found that for bad sinus disease, it actually was more costly than severe asthma, chronic migraine, heart disease, or diabetes. So all in all, that just goes to show that chronic sinus disease is more common than you might think, and we have a pretty huge opportunity to make a difference in our patients' lives. Moving on here to talking about chronic sinus disease, now that we've already gotten a primer in allergic rhinitis, there's a lot of overlap, as Dr. Acosta mentioned, but in general, chronic sinusitis is more severe and has a higher threshold for diagnosis. We have actually a formal classification based on our National ENT Society. These patients need to have at least 3 months of symptoms with 2 of the 4 of facial pressure or pain, decreased smell, runny nose or postnasal drip, and congestion. And beyond that, you also have to have evidence of inflammation on an exam in the office or imaging. So for most people who have not seen a CAT scan of themselves, this is what a CT scan looks like. It's kind of like you're looking in a mirror, but the sides are reversed. So left eye is up here, right eye here, and brain up top. Your sinuses are these air-filled spaces here that show up as black. So on top here, this is a pretty normal CT scan. And this might be the CT scan for someone who comes in with allergic rhinitis, as Dr. Acosta was talking about. On the other hand, below here, this is someone who has inflammation or gray throughout the whole thing. So oftentimes you'd need an endoscopy on physical exam in the office or imaging in order to be able to clinch this diagnosis here. Well, we just refer to this as chronic sinusitis. It's really not just a single disorder with a single treatment. There is a whole wide range of different diseases that show up as chronic sinusitis. Traditionally, this was divided into chronic sinus disease with or without nasal polyps, which is just based on what we see on our camera exam in the office. So apologies for the graphics here, but the top here is what the inside of the nose looks like in someone who is inflamed but does not have nasal polyps. These are normal inflamed structures. And on the bottom here, you can see there's nasal polyps filling the nasal passageway here. So traditionally, this is how we looked at patients. Do you have or do you not have nasal polyps? The problem with this, while it is a useful system, it does not help us to perfectly tailor our treatment to each individual patient. There's a variety of reasons why someone might have nasal polyps, and we've been working on, with our new technologies, a better system of being able to understand our patients. So moving on to our more modern way of thinking about patients, we have developed a system where we are grouping patients not on their physical exam, but on their underlying inflammation and pathways that lead to their symptoms, so that we're able to better target their symptoms. This graph here is from a recent paper, which is appropriately titled Contemporary Classification of Chronic Sinusitis Beyond Polyps versus No Polyps. The details of this graph are not important, but what is that all of the different types of sinus disease can be grouped into one of 2 types, either a type 2 underlying inflammation or a non-type 2 underlying inflammation. And I'll go through how we as ENTs are able to categorize our patients and be able to tailor treatments based on this. So starting with our type 2 patients, these are in general more common. These are the folks who think that they may have allergies, but really have severe symptoms. So often with asthma or eczema or seasonal allergies. They have a higher rate of nasal polyps than the general population, but they don't necessarily have nasal polyps. And what's nice is that we have identified a specific pathway of inflammation that's causing symptoms for these patients. And as a result, we have targeted therapies such as biologics and other ones that we can give to these patients specifically. As physicians, we know that these patients do well with steroids. So oftentimes we will give a short course of oral steroids and these patients will feel much better. In the long run, it's not safe to give oral steroids. So what we're able to do is give steroid sprays such as Flonase or Nasacort, or we can put steroids in rinses like Netipot or Neomed, and patients can stay on this long-term and get a significant benefit. The mainstays of therapy for these patients are topical steroids through their rinses. And if patients aren't happy with their response to this medical treatment, these patients have a significant benefit from undergoing endoscopic sinus surgery. So for most patients, a combination of sinus surgery and topical rinses are going to make them feel much better. For the minority of patients who still have polyps and severe and recurrent disease, that's where biologics come into play, specifically for these type 2 patients. A quick note here on sinus surgery, since we get a lot of questions on what exactly this involves. Looking again at our CAT scan on the top here, we have a patient who has inflammation throughout. So all of this gray here is inflammation, and all of the white part here are the little bones that make up the cells of the sinuses. What we do during sinus surgery is we remove all of these small bones and inflammation that you don't need. So in the process, we're removing inflammatory tissue. And then you wind up after surgery with this open area that the topical steroid rinses can then reach. So it's really twofold. These are done endoscopically without any incisions on the face, and this is done asleep under general anesthesia. We know that for these patients, not all sinus surgery is created equal, and there's a pretty wide range of surgery that your surgeons can elect to perform. Over recent years, I've been part of a group that has looked at the extent of surgery for these patients with nasal polyps. Looking here on the graph on the left, these are patients who've had previous surgery for nasal polyps and have come back with persistent symptoms. In the red, you can see we've given these patients a score between 0 and 100 in terms of how complete the previous surgery was. And for these patients who haven't had a complete surgery, they subsequently underwent revision surgery and they had their score go much higher. These patients had a significant benefit to getting revision surgery. And all this is to say, for these type 2 patients with polyps, there really is a benefit to going somewhere that you can get complete surgery and get maximum benefit from undergoing this procedure. Moving on to biologics for type 2 patients, Dr. Acosta did a great job going through the mechanism of how these things work, but this is particularly useful for sinus patients with comorbidities like asthma or severe eczema, or for polyp patients with prior surgery who are on medical treatment but just still aren't doing as well as they'd like. And this is very nice because it is specifically targeting points along the pathway that underlies these patients' symptoms. So to summarize, those were type 2 patients. These are the classic allergic patients with asthma or with eczema who show up with allergies, but also we find have sinus disease. Beyond that, we've identified a group of non-type 2 patients. These patients are best likely to have nasal polyps and interestingly tend to be folks who show up a little older with new sinus symptoms or are smokers. And there's a variety of different disease types within this, but they really do tend to share a common pathway. Unfortunately, for these patients, we found out that they don't respond to the same steroids that we give most of our sinus patients. They do well overall with sinus surgery, but we're finding that we can give specific tailored medical treatment after surgery that really benefits these patients. And this is in the form of a long-term low-dose antibiotic therapy called macrolides. So this is a more recent development. Some clinicians have started giving essentially one pill from a Z-Pak 3 days a week for 6 months, and they found that some patients do very well. It turns out that these patients are the same folks that have a different inflammatory profile than your classic type 2 patients. These are older patients, often smokers with less of a response to steroids. So it turns out that these are your non-type 2 patients, and we have a good treatment for these patients in the form of macrolides. Kind of where we are right now is identifying these patients as early as possible. We are doing studies that we can look at the tissue from surgery and see if there are different predictors that would tell us who is going to respond to this versus who's going to respond to steroids. So to summarize, chronic sinus disease is common, not quite as common as allergic rhinitis, but very common and has an outsized impact on quality of life. We have developed a new philosophy about classifying these patients with chronic sinus disease, and your specific treatment plan should be tailored by an ENT to your type of sinus disease. In general, the mainstay of treatment is topical steroid rinses through things like a neti pot, with sinus surgery for those who still have symptoms after doing their medical treatment. And more recently, we have more targeted biologic therapy for these type 2 individuals with severe disease after sinus surgery. And we also have new targeted medications like macrolides for these other types of patients that we're learning more about. Thank you guys for the opportunity to talk to you today.
Thank you so much, Dr. Lerner. So it's like it's sort of a mixed bag, and as we're about to launch our Q&A section here, so many questions coming through about chronic use of medication over the years and what's sinusitis and what's allergies and all this stuff. So it looks like the future's looking brighter with all this, the new biologics being approved and waiting for FDA approval and all that. But in the meantime, let's go into some of the pre-selected questions that they asked in advance. Dr. Acosta, if you want to join us as well, because he's going to be directed to both of you. But we'll start off with the first one. Are allergy shots effective? I know that you both presented on allergy shots, but how long does it take before symptoms are reduced with allergy shots? So they take it a step further.
Yes, we definitely know that allergy shots are effective, but that depends on many factors. Allergy shots is a commitment. The recommendation of allergy shots is between or at least 3 years. And if the patient can commit, ideally between 3 to 5 years. So the efficacy of the allergy shots depends on the antigens that we put in the vial, the dose, and also the compliance of the patient, okay? This is something that is going to change your immune system after 6 to 9 months. So if I tell you that you have to go to the clinic to receive a shot every week, right? And that you are not going to see any results until 6 to 9 months, sometimes that is discouraged for the patients, but we know that works. It works because it decreases the symptoms, it decreases the need for medications, so the patient have less symptoms and need less medications. And as I told you in the talk, this is the only treatment that can change the course of the disease. Allergy sprays, nasal sprays, allergy pills are going to treat symptoms, but it's not going to change the course of the disease. We know that allergy shots are effective. The patients that we have in the clinic that are on shots that are decide to do this marathon are very happy.
Yeah. So here's a follow-up before we
Yeah.
get Dr. Lerner in the picture here. So this patient says allergy tests in the past have all been negative, yet I get a sinus infection / cold. Is it apples and oranges? One thing has nothing to do with the other, or does it?
That's the patient. Sorry, I
And
didn't.
that their allergy tests were all negative, yet they get chronic sinus infections and
Okay, so we have to see which allergy testing this patient have. We have two type of allergy testing, and there's no perfect test, okay? If I do skin and I have a high suspicion that my patient have allergies because of the history, I can also ask for labs and vice versa, okay? And also in this patient, we have to see the symptoms. There is also something called oral allergy syndrome, in which the patients can develop allergies when they eat usually fruits because of cross reaction with pollens. So we need to do a physical exam and a detailed history.
If
all
I
right,
could jump in there as well. It's a great question because I think it gets to the heart of the whole idea of the talk is this allergies or is this sinusitis? And Dr. Acosta, of course, is correct that, you know, a negative allergy test doesn't mean that you don't have allergies per se, but these symptoms might not be just from allergies. I think in general, we refer to having sinus symptoms always as being allergies, but as I was talking about, it can be this type 2 type of inflammation that's related to allergies, but it could also be a host of other things. And for that reason, if you're having symptoms and you don't have an answer, a lot of these patients suffer in silence. And I would go see someone like an ENT who can get a better history, do a physical exam, decide if a CAT scan is warranted, because there are treatments and it's not only about allergy testing, although that's a big part of it.
The other possibility with this patient with a negative allergy testing is a non-allergic rhinitis, as I talk. You know, there are certain things that can be causing this inflammation in the nose that is not allergies or is or not sinus disease. And yes, you need to see a doctor.
All right, how about room air filters? This person wants to know, are they a placebo? We all have them. We're all guilty. We have them in our bedrooms or whatever.
That's yeah, that's very interesting because the majority of the research are done in patients that have like having the patients with multiple avoidance measures and not only with HEPA filters. You know, there's no research about HEPA filters efficacy alone, okay? We know that the filters can capture 99% of the particles that can be causing allergies, and we know that work, but usually work along with other avoidance measures. I have one.
I was going to ask. Didn't want to put the pressure on you. How about, okay, these are two specific medications that people are asking over the counter, actually. Astapro versus Afrin.
Super important. Super important question. Why? Astapro is a spray that is antihistaminic. Is a spray for allergies. And the Afrin is a topical decongestant. We are talking about two different things. People cannot use Afrin for more than 3 days. It can damage your nose, okay? It can cause worsening of the symptoms, even when the patients feel like, I breathe amazing. This over time can damage your nose, okay? You can use Afrin if you have a cold and you are congested, you use it for 1 or 2 days. But if you have allergies, Astapro is a good option, which is a celestine, because you can use a long lasting and it can decrease the inflammatory response in your nose.
And Dr. Lerner, how about Flonase? One of the questioners was saying, I keep using Flonase. I've used it for years. It helps, but it doesn't help. What's the answer there?
Yes, I think that Flonase is kind of your entry-level medication to this world of allergic rhinitis and sinus disease. A lot of people ask if it's safe to be on long-term, and the answer is yes. People should know that you can get headaches or nosebleeds from it sometimes, and we know that's a side effect. That being said, just because you aren't feeling 100% better from Flonase doesn't mean that you're not on the right track. So like I said, it's like your entry-level thing. So if you come see an ENT like myself or Dr. Acosta, we will add additional things depending on your symptoms or depending on whether you have allergic rhinitis or chronic sinusitis. It is a good medication and it's safe to be on long term.
And Dr. Acosta, in your presentation, I saw that you were talking about the fact that we have warmer temperatures and longer and, shorter winters. And therefore, that kicks up more of the allergens. So this questioner is saying that he or she believes that environmental changes have increased these pollutants and therefore the atmosphere, and that they are having a tough time filtering it all out. What else can they do?
So this is very interesting. We see patients in clinic that never had allergies, never. And after 30, 40 years, they say, hey, I'm having symptoms of allergies, and this is 100% related to the climate change. And we recommend the patients, you have to see which season is the worst for the patient, but we recommend like the avoidance measures, okay? Like exercise in the afternoon. I like the patients to check to track the pollen levels. There's many apps, and if you see that the pollen levels today are going to be super high, so you have to limit your activities, your outside activities, okay? You can also use HEPA filters, air purifiers if the symptoms are indoor, okay? Cleaning, that's very important for those mild allergens. And basically everything that you can do to avoid the exposure, which is not always possible.
And
Okay, as soon as you get home, for example, you just take off your clothes and put your clothes in the laundry room, because if not, you are taking the pollen that is sticking your clothes to your bed, to your sofa, and then you're gonna be exposed the whole, the whole day.
a chronic thing, but it's so difficult in beautiful South Florida where we're out and about. Even look at my virtual screen. I'm in a jungle and I'm wearing leaves on my blouse. You know what I mean? It's hard to say that to people, but nonetheless, Dr. Lerner, here's one for you because you are a loss of smell expert among your other expertise. Can a loss of smell be related to sinus infection? This person lost their sense of smell several years ago. I know, of course, some of it, COVID did some of the taste and so forth, but anyway, can loss of smell be related to sinus infection?
Yes, the short answer is yes. There is a bunch of different ways that someone can lose their smell, and we've learned a lot about this over the last 5 years with the spotlight being on COVID and COVID-related smell loss. The most common cause of smell loss, though, is chronic sinus disease. So for people who have decreased smell and are noticing that they have these other symptoms that we're talking about, they can often get their smell back if we treat them for their underlying sinus issues. That being said, there's a ton of patients who've had a bad sinus infection, trauma, or aging-related smell loss, and those are different categories. So I always tell people that if they have a question about it, they should come in. Same thing as these other conditions. There's a bunch of questions we can ask. We want to take a look in the nose and hopefully have a targeted treatment for each patient.
Dr. Acosta, this person was in the Q&A box listening closely to your presentation and said, so you said there is a correlation sometimes to allergies and rhinitis and these conditions in pregnancy. Does the same thing correlate to hormonal changes in perimenopause and menopause?
It can, yes, due to the decrease of the estrogens. Yes.
Incredible, something else to look forward to, right?
But not look in the case of menopause on those hormonal changes, it will be more a non-allergic rhinitis. So it's an irritation of the nose because of hormonal changes.
Let's jump in here to some of the other questions that are coming over. Let's see, have you either of you looked really recently to see if there's anything in here that that are open questions that are of interest to the full group tonight? Yeah. See, most of these questions are about the continual use of Flonase and Trelegy and so forth, and that fluticasone, I guess, is the active ingredient, right?
Mm-hmm.
And that is it's a good treatment depending on what they specifically have.
I have a question here that says on Ryaltris spray, the fluticasone is a steroid, intranasal steroid. The acetylene is an antihistaminic in a spray. Okay. We can use, we usually start using one, and if the patient is not better, you can add the second spray. There is a question here about Ryaltris. The Ryaltris spray is the combination of both substances, like fluticasone plus acetylene, and it's an amazing spray.
Well, here's an interesting one. Can chronic sinusitis or chronic rhinitis aggravate tooth pain or TMJ rather?
They can often be related. So we talked about how there's a bunch of different causes of chronic sinus disease. Dental issues actually can be a trigger for it. So a lot of times when I see patients, we learn that the underlying issue might be someone who needs a root canal. So we actually work often with dentists to address the underlying problem. TMJ is not as much of an overlap, but it's a really good point. A lot of time dental pain is actually a sinus issue and vice versa.
You have mentioned that the neti pot, which has now gone forward to the navage, cleansing of the nasal passages and all that. Is that something that we should all be doing, or only if you suffer from allergies or this kind of conditions, or is it prevention?
I wouldn't recommend doing it if you are not having symptoms. I mean, even for the folks who have sinus disease or who have allergic rhinitis, it's kind of annoying to do because you are spending 2 times a day preparing it and irrigating over a sink or in the shower. But if you're having issues, it does really help. So the people who have, who are really bothered by it, they really have no problem doing this every day because it helps them. For Dr. Acosta's piece on the folks who are allergic, you walk around outside on a day with a lot of pollen, you are getting home and you're washing out all the pollen from your nose. If you're someone with chronic sinus disease, you need the steroids in there. And what's important is that you're delivering the steroids to the inside of your nose twice a day. So it does really help. I don't know if I would say that everyone needs to do it, whether or not they have symptoms, but it's a great medication.
It's good marketing. It's what. Zyrtec, Claritin, all of these over-the-counter that everyone, so many people seem to be taking continually. Good, bad, helpful, not helpful, depends on your diagnosis.
Yeah, the patients that have perennial symptoms, like all year round, unfortunately, some of them have to take antihistaminics all year round. So every patient is different, right? We have patients that only need one nasal spray and not allergy pills. We also see patients that need the allergy pill plus the spray. Again, avoidance is the non-negotiable here, okay, to decrease exposure, but it's safe. There are certain conditions like patients with prostate hyperplasia. Those patients can have urinary retention with allergy pills, and these patients might be better to put them on a spray. But the answer is yes. If you want to reduce the amount of medication that you take and your symptoms are not better only on avoidance and medication, you should consider immunotherapy.
Okay. Is any of this hereditary? Sinus problems, anything like this that is actually familial?
Yes, absolutely. Yeah. So the different pathways of inflammation that I was talking about, some people pass on increased inflammation on these pathways. So the same way that your mom or dad had asthma and now you do, the same thing. Chronic sinus disease tends to run in families.
Can allergic rhinitis, this person asks, actually cause asthma, or two different pathways, two different things, two different diseases?
Very interesting. There is
Great
the
question.
concept, there is a concept of unified airway. So we no longer say is upper or lower, they are connected, okay? 80% of the patients with asthma have allergic rhinitis. And 40% of the patients with allergic rhinitis have asthma. And also, patients with sinus disease also can be or can coexist with allergic rhinitis. It is, there is something called atopic march, where you see that the patients start with maybe skin allergies and then develop allergic rhinitis, and later on life, they develop asthma. So yes, they are correlated.
I'll add to that last piece there. Treating asthma helps your sinus disease if you have both, and treating sinus disease if you have asthma helps your asthma. So they really are connected, and treating one helps both. I mean, you have a medication, a biologic like Dupixent, that has an indication for both those things. So you are kind of taking care of your whole body by doing this. I do want to add, just kind of as a takeaway from our talk on allergies and sinusitis, as you saw, these are both so common, and this does really affect patients. And we've both found that a lot of people are stuck with doing the first line treatment. They're stuck with just doing the basic sprays over the counter. if you are suffering from this, like there are a ton of different targeted options, and we do have a much better understanding of what's going on, and there is a lot of opportunity for improvement in quality of life. So if there is maybe one takeaway, it's that you don't need to be stuck with your over-the-counter sprays if you're still having issues.
Thank you for that, because I think that was a valuable piece of information. We're all sort of desperately shooting from the hip. Is it this? Is it that? You need to be seen by a professional, which leads me to the question, is your practice and at UHealth treating both pediatric and adult patients for these conditions?
As for me?
Yes.
Yeah, okay, no. We have in the University of Miami, we have a division of pediatric allergies. Okay, so yeah, like in ENT department, we only treat adults.
Right, so it's two separate entities. So would you say that as we're wrapping up and we have 4 minutes left to go, and the questions keep coming, so I think that the answer for a lot of these people who have tuned in tonight, almost 200 people, is to go to the contact information when we put that screen up at the end shortly here, and contact your department and see what they can do to get help. But what I heard as the takeaways here is that help is on the way. There's more and more treatments being approved and being tested. So give us a little take-home message of hope and optimism. Both of you, just 30 seconds.
Yeah, I'll just reiterate my point. We have a much better understanding of why different people have different symptoms. It's not just sinus issues. It's not just allergies. We have pretty good diagnostic tools to figure out why you are having your specific symptoms, and we can tailor the treatment for what it is for you. And we have several options.
And
Yeah.
Dr. Acosta, the future is here.
Yeah, the future, biologics. I think that the most important of this talk is that people understand that even when we have a disease that share the same symptoms, it can be something totally different. You can have patients with facial pain having migraines. That's very common, and I think that the consultation, that the ENT consultation, a specialist consultation, is the most important for the evaluation of the patient.
Well, this has been so valuable and certainly probably relieving for so many people, because summer is here, by the way, if you haven't noticed. The heat index is through the roof. And there's the information again that we were referring to on your screen. You can even take a picture of the QR code and scan that for you to reach out to this department to help you and see if you're a patient, or you can seek help. Also, this talk is going to be sent to you, the link, so it has been recorded. So everyone who listened tonight and tuned in, you're going to be able to hear this and see it again calmly and be able to absorb more of the information. But we cannot thank our experts enough for the privilege of your time and for a very engaged audience for taking part with us tonight. So Dr. Lerner, Dr. Acosta, we thank you so very much. Thanks for being with us, because we at the University of Miami appreciate everyone's participation. Again, there's the info on your screen, and to schedule appointments, you can also go to the new Doral facility, which is incredible, state-of-the-art, world-class. So thanks to everyone tonight for the privilege of your time, and stay healthy, stay well, and we will see you again. Good night, Dr. Acosta, Dr. Lerner.
Bye.
Thank you for having us.